Good afternoon, guys. How you doing?
Good.
So far, so good.
Feel like on vacation.
Ready for vacation? Spring break? Nice. The exam would be after the vacation, right?
Yeah.
The spring break. Nice. I see so many people missing. Do you guys have exams or anything? Huh? They're eating. Of course, eating versus class. Of course. Oh, I see more people coming. Good. Are you able to see the monitor? Is the light okay? It's okay? Hi, how are you? Hi. Hello. Okay, so last lecture we talked about anthelmintic, and we said that's the only part that's going to be covered in exam one. And then we also talked about one half of the antiprotozoal, and then today we'll cover the second half. Okay, so the antiprotozoals, both, the first half and second half would be in exam two. Okay, just wanted to remind you. I know I said that already. And after the antiprotozoals, we'll also talk about the disinfectants, sterilants, and all that fun stuff. Any questions before we start? All right, so to continue with the antiprotozoal, the next example are actually chemotherapy for malaria. Okay, so malaria is, so we'll start with an introduction just like we did with the amoeba. We'll talk about some terms and then the life cycle of malaria, and then we'll talk about the drugs. So it's an acute infection, infectious disease caused by 4 species. So there are 4 different species of protozoal plasmodium, and they are transmitted through the bite of a female Anopheles mosquito. So the mosquito female is responsible for the transfer of those protozoa, as we will see soon. There are 4 different kinds of this protozoa that causes the malaria. The first one and most dangerous one is the Plasmodium falciparum. Okay, it's the most dangerous, causing acute, rapidly fulminating disease that is characterized by persistent high fever, orthostatic hypotension, and massive erythrocytosis, which is an abnormal elevation in the number of red blood cells accompanied by swollen reddish limbs. Okay. The Plasmodium falciparum infection can lead to capillary obstruction and death. Okay, if left not untreated. So that's the most dangerous species of the malaria protozoa genus. The second one is Plasmodium vivax, which cause a milder form of the disease, and then we also have Plasmodium malaria, common to many tropical regions, but within we also have Plasmodium ovale, which is rarely encountered. Okay, of course, just like with all the microorganisms, there is always resistance acquired by the mosquito to the drugs that we have for this disease. So far, so good. All right, let's look at the life cycle of the malaria. As we said, there is the female mosquito that could inject something called sporocytes. Okay, and this could also happen by contaminated needles. So you might also get the same effect. So sporocytes will then will transfer to the liver and infect the hepatocyte. Okay, and inside the liver they multiply and form what's known as merocytes. Okay, so after they migrate to the liver and infect the hepatocyte, they convert into merocytes, and then as they multiply, they burst, the hepatocyte bursts, and then those merocytes are released into the blood circulation and then infect the red blood cells. Okay, and inside the red blood cells, they are converted into trophocytes. Okay, trophocytes then multiply and cause bursts of the red blood cell, and they give something called gametocytes. Okay, the gametocytes will be taken by the same like female mosquito, and then they are converted inside the mosquito into the sporocytes, and the life cycle continues. Okay. Of course, as we said, those sporocytes could also be entered through like infected needles. Now, what's interesting is that some of the drugs, or actually most of the drugs, act on the protozoa when they are inside the red blood cells, and so they are known as erythrocytic form. So they act on the erythrocytic form of these protozoa. We only have one drug, which is primaquine, that could act on the what's known as exoerythrocytic form, such as the merocytes and also the gametocytes. Okay, so that's the only exception. That's the only drug that acts on the gametocytes and the merocytes. Everything else acts on the erythrocytes, which are the trophocytes. Questions about that? Any questions? Yes. Do we have to know the life cycle? We don't. It's just, it helps us later on when we talk about drugs that act only in certain forms. Okay, Eric?
I noticed that, like, you said, like, drugs effective against, like, the erythrocytic form, and there's, like, a lot in terms of the list. Is there,
Yes.
like, distinctive differences between, like, which one is, like, the better one to use out of the ones in the list, and is there, like, specific side effects about?
Yes, absolutely. So we will go through. So the question was about those that act on the red blood cells. Are they the same, different side effects? We will go through that next. Okay. So we'll talk about each one of these mechanism of action, side effects, and so forth. Okay.
Okay, thank you.
Absolutely. Any other questions? Good. All right. Okay. So the first example of these drugs is the quinine, which is isolated from the bark of Cinchona tree. Okay. So examples of drugs in this class or derivatives are things like chloroquine, hydroxychloroquine, as we will see soon. Quinine is reserved for severe infestations or for chloroquine-resistant malaria strains. Okay, it's usually administered in combination with doxycycline, tetracycline, or clindamycin. It's taken orally. It's well distributed throughout the body. The major adverse effect of quinine is something called synchonism. This is coming from the tree, Cinchona tree. So there's something called synchonism, which is a syndrome causing nausea, vomiting, tinnitus, vertigo. These are reversible. Okay, so they are not reasons for stopping the disease. You know, usually if the effects are irreversible, that's when you worry. You want to stop the drug. However, quinine treatment should be suspended if hemolytic anemia occurs. Okay, so that's one of the rare adverse effects, serious effects. If you see hemolytic anemia caused by the quinine, then you would stop the disease. Okay. Lastly, there are drug interactions included when you administer quinine with digoxin, mostly because of interacting at the the neuromuscular blocking agents. They potentiate. They actually, induce the neuromuscular blocking effect of digoxin, and so they should not be taken together. Okay. Also, as far as absorption, pharmacokinetic properties, quinine absorption is reduced by aluminum-containing antacids. Okay. Any questions about this slide? Clear? Okay. All right, let's look at derivatives of the quinine. So this class of drugs could be classified into two categories. We have something called 4 substituted quinolones. So this group here is actually the quinolone. Okay, and we have 4 substituted quinolones. Everything here belongs to this class, 4 substituted quinolones, and they will have their own mechanism of action. Okay, and then we also have 8 amino quinolones. So at position number 8 here, we have the amino quinolones, and this class or category of drugs, it has a different mechanism of action. Okay, which would help us actually maybe understand why this class, primaquine, acts on the exo erythrocytes. Okay, unlike everything here that works in the erythrocytic form. Where did this come from? 4 substituted quinolones. If you count, let me erase that. Okay. Okay, so if you, starting with the nitrogen, if you count 1, 2, 3, 4, that's where the 4 substitutions come from. If you continue, there is 5, 6, 7, 8, and that's where 8 here is come from. So again, 1, 2, 3, 4, 5, 6, 7, 8. So just by looking at the structure and start counting from the nitrogen in this direction, you could tell whether it's an 4 substituted or 8 amino substituted quinolones. Okay, just make sure you differentiate between these two categories. Okay, because that's going to affect the mechanism of action. Okay. All right. And then, for example, in the case of the quinine and quinidine, okay, the difference between them is on the OH substitution. So one of them is like the isomer of another one. So on one of them, the hydroxyl group is on this side. On the other one, the hydroxyl group is on this side. That's the only difference between quinine and quinidine. Okay, and we will see next very soon something called chloroquinine, which has a chloro on the position 7, and there is also hydroxychloroquine, which has hydroxy on one of these methyl groups. Okay, so if you see hydroxy and chloro, then you would know it's a hydroxychloroquine. If there is no hydroxy group, then you would know it's a chloroquine. And then finally we have the mefloquine, and then we have the lumefantrine. Okay, so all these have the same mechanism, and they're known as 4 substituted quinolones. Questions about that? Eric, no questions?
No.
Okay. Maria? No, I'm sorry, maybe I forget the name. I'm sorry, I forget your name. Any questions? No, you're good? Oh, there's Eric.
Okay, there you go. Right, I had one. Right, for chloroquine to be hydroxychloroquine, do you know which specific reaction that needs to occur to be hydroxychloroquine?
I mean, to convert it to hydroxy? So this is actually synthetically designed. It's actually the hydroxychloroquine, as we'll see soon. It has less side effects. It's less dangerous. Okay, hydroxychloroquine has actually, well, both of them could be used for malaria, but hydroxychloroquine specifically could be used for rheumatoid arthritis. Okay, so it has a dual pharmacology effect. Okay.
Okay, thank you.
Sure. But the hydroxychloroquine is safer. Any other questions? All right, so the take-home message, make sure you differentiate which ones are 4 substituted, which ones are 8, because it's going to affect the mechanism. Okay, guys? Do not memorize the structure for each drug, but make sure you classify it to what category and then which mechanism of action, because we will see that this class has different mechanism of action than that. Okay. And then chloroquine, hydroxychloroquine, I mean, it's not memorizing the structure, but if you just look at the hydroxy group and the chloro group, then you should be able to tell that it's chloroquine or hydroxychloroquine. So far so good? Right. Right, let's start with the chloroquine. It's synthetic 4-aminoquinone. As we said, it's 4-substitution aminoquinone. That has been the mainstay of anti-malaria therapy, the drug of choice for treatment of erythrocytic Plasmodium falciparum malaria, except in the case of resistance. Okay, it's less effective against the Plasmodium vivax malaria. It's highly selective for the asexual form of the Plasmodium. Okay, which is, I believe, the gamocyte. I think it's called. I think that's the asexual form. It's used as a prophylaxis of malaria, although at lower doses. Okay, for people who are traveling for regions where there's malaria, and this malaria is known to be sensitive, because some malaria has become resistant to chloroquine. So if you know somebody is traveling to an area that has malaria that's sensitive to chloroquine, then you could give them chloroquine as a prophylaxis before they travel. I think they start like a week or 2 weeks before the trip. Okay. As we said, the difference between them is the presence of the hydroxy, and the hydroxychloroquine is actually has less side effects. It's an alternative. So hydroxychloroquine is alternative to chloroquine. Let's say somebody cannot tolerate the side effect of the chloroquine, you could switch to the hydroxychloroquine. Oh, okay. Now, if the drug is resistant to chloroquine, what do you guys think? Let me see if you could guess. If the drug if the malaria is resistant to chloroquine, do you think it would be also resistant to hydroxychloroquine? You wanna guess? Yes, because they're very similar. Okay. Okay. And you might remember from previous class that chloroquine was also used in the extra-intestinal amoebiasis, the systemic treatment amoebiasis. We've talked about that already. And as I mentioned, hydroxychloroquine is also used for rheumatoid arthritis. So far so good? Any questions? All right. Okay, now let's talk about mechanism of action of the chloroquine, but this applies not only to chloroquine, this applies to all the 4 substituted quinolones. Okay, so everything here, this is mechanism of action for everything here. Quinine, quinidine, chloroquine, hydroxychloroquine, mefloquine, and lumefantrine. I wonder why this has a different name. They should change it, make it something quinine, to make it easier. Okay, so as far as mechanism of action, the short description for the mechanism of action is it interferes with heme polymerization, resulting in death of erythrocytic form of the Plasmodium parasite. What does that mean? So apparently, when this parasite, this protozoa, when it attacks the red blood cells, it actually consumes hemoglobin. You guys remember from your biochemistry the hemoglobin? It's like a tetramer or four different proteins attached to each other, and there's inside each one of them there is the heme structure, iron with the heme molecule, and each one of these 4 units carries the oxygen molecule. Remember that? Okay. Anyway, so this parasite digests the amino acids from this protein, all these four units, and results into 4 heme remaining. Okay, so those heme, okay, if they are left without packed together or polymerized together, they accumulate and they actually cause death to the parasite itself. Okay, now the parasite usually pack those heme into something called hemozoin. they pack them into polymers. They link them together. See these links between them? They link them together. That's what normally happens if the, in normal conditions. That's what parasite does. So mechanism of action of the chloroquine is it actually prevents the packing, the polymerization of the heme into the homozoin. As a result, they remain floating inside the parasite and cause the death and the lysis of the parasite. Make sense? Yes, Eric?
Yeah, I was just curious, right? Like, I know with the accumulate that kills off the parasites, but I guess it's just a process. But why do they convert it into hemozoin? Like, is that just like the process to go in? I guess digest or?
Well, I'm honestly not sure like what's the purpose of polymerizing them together, but apparently they found that by applying chloroquine, those heme molecules are not polymerized, and then the theory proposed is that because of that, they accumulate and cause death to the parasite. In fact, this the exact mechanism is not fully understood, but this is just the hypothesis that's been accepted so far.
Sounds like you're kind of just letting the proteasole kind of just bleed out.
Yes, it's more like, yeah. So because you're going to have so much of these heme accumulating by destroying the hemoglobin, and then those accumulations are going to cause the death of the parasite. Now, the erythrocyte is going to die as well, but it's going to die regardless. The erythrocyte, the blood cell which has the parasite inside it, it's going to die anyway, but by administering the drug, you're killing the parasite as well, not just the erythrocyte. Okay, sure. All right, so just remember this applies to all the 4 substituted quinolones. Okay, guys, any questions? So far, so good? You're enjoying your food? So what was the occasion? Why? Huh? Nice. Oh. Because I thought there was also one tomorrow, right? From 12 to 1? Maybe that's... Oh, today I missed it. Okay. No, I was just kidding. It's good. You have extra? Thank you so much. Good. Excellent. Okay. So no questions on the mechanism of action. Good. All right, pharmacokinetics. Chloroquine is rapidly and completely absorbed by oral administration. It has a large volume of distribution, as we'll see. Why? Because it distributes to the erythrocytes, leukocytes. It also crosses the blood-brain barrier, goes into the CNS. It also crosses the placenta. It remains in the erythrocytes, which is nice. It accumulates in the erythrocytes because that's nice because that's where the drug actually acts the most. And then chloroquine is as far as metabolism, it's dealkylated. So that's an alkyl group here. So this is removed, or could be that, if there is no H group here. It's dealkylated as far as metabolism, producing metabolic products that retain anti-malarial activity. So some of the metabolic products could still have the same anti-malarial effect, which is nice because that's going to prolong the duration of action, right? Whenever you have an active metabolite, what does that mean? How is that important? If the drug is metabolite to something and that something is active, increased duration of action, right? The best example of this is diazepam, right? Just to link it. Okay, so both parent and metabolites excreted primarily into the urine. What does that help us? Why do we care about this information? Kidney failure. So if somebody has kidney failure, you would have to adjust the drug. Okay? Yes. Oh, okay. In the antiviral? I can't remember, sorry. But the concept applies regardless. Anytime you have an active metabolite, you're actually increasing the duration of action. I think with the antiviral, I think it was inactive to start with. It was a prodrug, so that's different. Okay, so in the prodrug, you have something that's inactive, but then get converted to the active form. But if you have both the drug and its metabolite active, then you have a longer duration of action coming from both of these two. Okay. Any questions about here? So far so good? Okay. Adverse effects. So as we said earlier, chloroquine is used as a prophylaxis, but it's given at a lower dose in the case of prophylaxis, okay, as a prevention. In that case, the side effects would be minimal. But if they're used for treatments, then we'd have to use higher doses, which would result into GI upset, pruritus, headache, and blurred vision. And because of the blurred vision side effects in the chloroquine, the ophthalmologic examination should be routinely performed. Okay, so I do expect you to know these. Mostly the blurred vision side effect, skin rash, of course, GI disturbances occurs with most drugs, but of course, headache, skin rash, blurred vision as side effects for chloroquine. Okay, related to the skin rash, also the discoloration of the nail beds and the mucous membranes. Okay. The drug should not be used in patients who have hepatic dysfunction, or if they have severe GI problems. Obviously, that could exacerbate that, or if they have neurologic disorders, because the drug crosses the blood-brain barrier reaching to the CNS. Patients who have psoriasis or porphyria, these are skin diseases. They should also should not be treated with chloroquine, because that's going to cause acute attack, basically exacerbate, increase those skin conditions. And then finally, one of the important side effects for chloroquine that I also expect you to know is something called QT interval prolongation. You guys have seen that before, QT prolongation? What would the result, what would that cause if you have any drug that causes QT prolongation? What would that lead to? Arrhythmias. Thank you so much. Okay. All right. So any other drug that might cause QT prolongation should be avoided, or combination of these two drugs should be avoided. Any questions about this slide? Yes, Eric.
What's the difference between psoriasis
I know what psoriasis is. It's like an autoimmune disease. I honestly couldn't remember the porphyria. Sorry. That's a good question, though. But I believe it's also a skin condition, disease. So far, so good. So just make sure you catch the blurred vision side effects, and as a result, people who are taking chloroquine should have routinely check with ophthalmologist. Of course, the skin rash and discoloration, and there is QT prolongation, okay? And these, yes?
I kind of searched this up, right?
Yes.
It's a group of, it's called also known as vampire disease. Okay, a group of inherited blood disorders resulting from the buildup of certain chemicals related to red blood cell protein.
Oh, so it's not a skin condition. Sorry about that. Okay, so it's like it's a blood cell disease. Okay, which makes sense because the drug acts on these red blood cells. So by having any of these conditions for patients, you should avoid chloroquine. Nice, thank you, Eric.
Thank you.
Any other questions? No questions? Okay. The next one is mifloquine. Can you tell from the structure, is it 4 substituted or 8? It's 4 substituted, okay? 1, 2, 3, 4. So it would have the same mechanism of action with the chloroquine. It's effective single agent for prophylaxis and treatment of infections caused by the multi-drug resistant form of Plasmodium falciparum. So in the case of resistance, okay, of the multi-drug resistance form of the Plasmodium falciparum, you could use mifloquine, okay? Resistant strains have also been identified in some regions like Southeast Asia. It's well absorbed orally and widely distributed into the tissue. It has a long half-life of 20 days because of something known as enterohepatic circulation, and because it concentrates in various tissues. So you guys remember enterohepatic circulation? You guys remember the enterohepatic circulation? Okay, you know how the drugs that are metabolized by the liver get excreted where? Through the bile duct into where? Into the intestine. But we also know that most of the drugs are absorbed where? From where? They're absorbed from the stomach, but mostly from where? From the intestine. So some drugs, after they are metabolized and excreted into the intestine, guess what? They get reabsorbed again. So now they have another turn of being active on the, have another pharmacological effect. So this circle is known as the enterohepatic circulation. Okay. Now sometimes the drug itself is excreted and gets reabsorbed. Sometimes the metabolite is excreted and it gets reabsorbed. If the metabolite is active, guess what? You're going to have a longer duration of action. Okay. So mifloquine, because of enterohepatic circulation, it has a very long half-life, 20 days. Usually drugs have half-lives in hours, but here we're talking about days. Plus the drug concentrates in various tissues like, fatty tissues or maybe the erythrocytic tissues. Okay, it goes extensive metabolism and primarily excreted in the bile, okay, into the feces. Extensive metabolism in the liver. What does that? What does this information help us with? Exactly, liver failure. Somebody who has liver failure, we should be watching for that. It's primarily excreted into the bile. How does that information help us? Again, if somebody has liver failure, you would be careful. But if somebody has kidney failure, what do you guys think? Would that be an issue? Would we have to adjust the drug dose? No, because it's mostly primarily excreted into the bile. Okay.
What about like bile stones?
Bile stones? Oh, that's interesting. So my guess would be, we have to confirm that with experiments. So my guess would be the same problem, just like having liver problems. Okay.
Okay, thanks.
Sure. Okay. Adverse effects: nausea, vomiting, dizziness, hallucinations, depression. Because the potential of neuropsychiatric reactions, mifloquine is usually reserved for treatment of malaria when other drugs do not work. So it's like plan B drug. Because of these neuropsychiatric reactions that mifloquine causes, it's reserved when other agents do not work. Okay. One of the interesting side effects are ECG abnormalities and cardiac arrest, and these are serious side effects. Okay. If taken concurrently with quinine and quinidine. So if the drug is combined with quinine or quinidine, then you would have ECG abnormalities and cardiac arrest. These would be possible. Questions? Yes. What would be the reason? Interesting. So the question is, what would be the reason to combine them if they have the same mechanism of action? Usually you would use different drugs, drugs with different mechanism of action. I guess I don't know the exact accurate answer, but my guess that there must have found some benefits clinically from combining these two drugs. That would probably cause a synergistic effect. Okay. Especially if sometimes even if you still have the same mechanism, but if you have different side effects, you could still combine them at lower doses. So you would achieve the efficacy, but you would have less side effects from each. Okay, that's a good question. Any other questions? Okay, Eric.
I was just thinking, right, like because the chloroquine and hydrochloroquine, they have like a longer chain with the four substitution, right? Versus like when you look at like the mefloquine, right? It's a little shorter. Does this mean that like maybe the oral bioavailability isn't that great for the mefloquine, or is that not really true? I was just thinking that.
Sure. So the question was because chloroquine and hydroxychloroquine has a longer lipophilic chain compared to that. So how is that going to affect the oral bioavailability? I mean, I think we said that both of them are taken orally, so they must be meeting, I mean, they must be, just to confirm this is taken orally, right? Does it say? I mean, it has intrahepatic circulation, so it must be taken orally. So they must, so both of them should have, I guess, meet the requirements for to be taken orally.
Okay.
But one of them, clearly one of them is more lipophilic than the other. So I mean, there's a range of lipophilicity for orally taken drugs, so they must be both of them within the same range.
Okay. All right. Thank you.
Sure. Any other questions? Okay, the next one is Primaquine. All right, is that a 4 substitute or 8? I should hide it. Okay, so it's an 8 substituted, okay? And so it has a different mechanism of action, as we will see, okay? So first of all, it's an oral antimalarial drug, eradicates the exoerythrocytic. As we said, we've said that all of the drugs we'll see today works on the erythrocytes, but there is one that acts exoerythrocytes, which has a different mechanism of action, which helps us too, right? So it's this Primaquine. So it has a different class, different mechanism of action at X and acts on the exoerythrocytes. Okay. Secondary erythrocyte forms. Okay, so of course, you know, different forms of plasmodium and these different forms. It's the only agent that prevents relapses in the P. vivax and oval malarialis, which may remain in the liver in the exoerythrotic form after erythrocytic is eliminated. So because it acts on the liver through exoerythrocytic, so it acts on the PVAX and P oval, and those forms remain longer in the liver. Okay, but we're not gonna memorize the spectrum of activity for the drugs anyway. So, but just it's good to link why this one is acting on other forms, because they remain longer in the liver. Okay. All right. The gamicytic form are actually the sexual. I think earlier I said the asexual one was this one. Anyway. Okay. So this forms, the sexual gamicytic forms, for all the Plasmodium species, are destroyed in the plasma or prevented from maturating later in a mosquito, thereby interpreting the transmission of the disease. Okay. It's not effective against erythrocytic stage. We said that already. We did not talk about mechanism. Oh, here we go. But before that, do you have any questions about this slide? It's used in conjunction with agents to treat erythrocytic forms. Okay, so I guess you could combine them with other agents that are used to treat the erythrocytic forms of the protozoa. Yes, Eric?
When would you really use something like Primaquine, like the exoerythrocytic versus the erythrocytic? Because we're saying that Primaquine is not effective against the erythrocytic, right? So is there a certain specific time you would use the erythrocytic versus the exoerythrocytic ones?
Okay, so the question is, when we would use Primaquine, what would be conditions that we would use it, especially that it's ineffective in the erythrocytic stage? Honestly, I think that would be more like therapeutic applications, like what conditions would be more suitable to use one versus the other versus combination. But as far as like mechanism of action, I can't really relate why could we use one versus the other. Okay.
All right. Thank you.
Sure. Okay, so it's not effective against the rights, and so it would be used with conjunction with those. Yeah, I'm just wondering if, like, should we be treating erythrocytic as well as exoerythrocytic, or one versus the other, or not? I guess that would depend on the case. Okay. Although I think at the end here there is a table. Okay, let's see. In the case of prevention, sensitive, in pregnancy, resistance, prevention relapses. Okay, so it doesn't help either. Okay, anyway. Any questions before we go to the mechanism of action of primaquine? No. Okay, mechanism of action. Just like with all the quinones, it's not fully understood. However, it's believed that metabolites of primaquine are believed to act as oxidants responsible for killing the schizonicidal, basically killing the protozoals, as well as hemolysis and methemoglobinemia, encountered as toxicities. So there is some oxidants. So the drug is metabolized into some oxidants that are responsible for killing the protozoa. Those oxidants also affect the host and causes toxicity such as hemolysis and methemoglobinemia. Okay, so that's its mechanism of action. Okay, production of oxidants as metabolites that destroy the virus. I'm sorry, the parasite. Pharmacokinetics, it's well absorbed orally, and it is not concentrated in the tissues, so must have a smaller volume of distribution. Rapidly oxidized to many compounds, primarily the deaminated drug, which possesses the schizonicidal activity, has not been established. Which compound that's not been established? It is rapidly oxidized to many compounds, primarily the deaminated drug. Which compound has not been established? Oh, so these metabolites don't have active activity. Okay, so when they are metabolized or oxidized into other products, they do not have the some of them do not have the activity. I guess there is certain metabolites that believe to have activity as oxidants, but others don't. Okay. It's minimally excreted into the urine. Any questions about this slide? So far, so good. Okay. Adverse effects. So for the primaquine, apparently it should not be given to anemia patients who have glucose 6-phosphate dehydrogenase deficiency. Why is that? So let me give you some background about this disease. So people who have glucose 6-phosphate dehydrogenase deficiency would not be able to produce the glutathione. Why? Because if we look at this mechanism, the enzyme is responsible for converting the glucose 6-phosphate into something with the help of NADPH, and this NADPH is necessary to help the conversion of the glutathione to molecules of the glutathione into the active glutathione. And so by not having this enzyme, it's going to interrupt the formation of glutathione. What do we know about glutathione? You guys remember phase 2 metabolism? What is commonly known and something we should know by heart about glutathione? Anybody?
Is this something associated with gluconization?
So it's glutathione conjugation. So in phase 2, we had glucuronidation as one example, which is the most common metabolic reaction in phase 2. But then we also have glutathione conjugation. Glutathione has a unique job, specific job, which is removing of toxic oxidants. So anytime you have molecules that are toxic, glutathione would take care of them. So if you have less of that, what's going to happen to the toxins? Then accumulate. Okay. Now with the primaquine, we already have the drug producing these toxic oxidants. Okay. So if you give the drug to somebody who already have this problem, so they are already susceptible to having oxidants, toxic oxidants built up. So if you administer it for people who have this disease, guess what? The chance of accumulating of these oxidants will be even higher. As a result, you would have something like methanoglobinea and anemia. Okay? Make sense, guys? Okay. Any questions about that? So in short, glutathione helps us detoxifying oxidants. If somebody has this enzyme deficiency, you would have less of that glutathione, and they will not be able to detoxify the oxidants coming from primaquine, and then they would have methanoglobinea. The drug should not be is not safe during pregnancy. Many of these drugs are not safe in pregnancy, but we should catch what these drugs are. We talked about them in previous class when we talked about the first half of the lecture. So please make sure you add this drug to the list of drugs that should not be taken for pregnancy. Okay, so that's something I would expect you to know by heart, because it's really serious. Okay. And of course, all Plasmodium species may develop resistance to primaquine, which is all drugs. That's true for most drugs. Any questions about this slide? So far so good? Okay, the next drug is actually a combination. It's 152. I think we have, let's see. Maybe, let's see how far we go in like the next 1 minute or two. Okay. All right, so the next class is actually a combination of two drugs. One of them is called the atovacone, and then there is the proguanil. Okay, combination of two drugs. Each one has its own mechanism of action. So atovacone inhibits mitochondrial processes such as electron transport, as well as ATP and pyrimidine biosynthesis. Proguanil is a prodrug that's converted or metabolized, converted into the active form, which is cycloguanil. So this is the proguanil. Notice that there is no cycle here, but then it's converted into the cycloguanil. So you form a cycle here. Okay, so this is the inactive form, this is active form. Okay, and this active form would then inhibit the dihydrofolate reductase of the plasmodial, and it would prevent DNA synthesis. Okay, so just make sure you catch those mechanisms of actions for each one. Just make sure you know the mechanism of action for each drug. This is a unique, we've seen examples of prodrugs, but what's unique about this conversion is the fact that it's performed using this CYP2C19 enzyme. I'm not sure if we talked about this already, about the importance of the CYP2C19. Do you remember? What's unique about this enzyme? There is CYP2C19 and CYP2C9. Those two enzymes have something special about them. What is it? Polymorphism. What does that mean?
There are some people that could genetically be born.
Excellent. Excellent. So some people might be genetically born with different levels of these enzymes. In fact, different races would have different levels of these enzymes. So that should be taken into consideration when we administer this drug. Preferably, if possible, if we could perform like DNA genetic tests to find if this person has this enzyme or not. Because if they don't, the drug will not be activated. Okay? And then finally, the combination of these two drugs should be taken with food or milk to enhance the absorption. Common adverse effects include nausea, vomiting, abdominal pain, headache, diarrhea, anorexia, and dizziness. Any questions about this slide? Do you need a break, or should we continue and finish? I think we probably need 2-3 minutes. That's nice. Okay, if we could finish. Okay, because we're going to start with a different topic. Okay, the next one is artemisinin. Okay, it's the artemisinin and its derivatives are recommended first-line agent for treatment of multi-drug resistance falciparum. So when you have malaria that's resistant, then you would consider this as the first-line treatment, the artemisinin and its derivatives. Itself, artemisinin is actually a prodrug, okay, of the dihydroartemisinin. So this is a drug, inactive, okay, and it has to be converted into the active form, which could produce other active metabolites, okay. Now, its mechanism of action is through the conversion or the break of something called endoperoxide ring. If you look at all these structures, there is something called endoperoxide ring, okay? When this ring comes in contact with the iron oxide in the hemoglobin, it breaks and forms free radical, which are responsible for the damage of the proteins and the death, and of course the death of the parasite. That's the mechanism of action. So with the help of the iron in the hemoglobin, this essential group, endoperoxide, breaks and forms radicals. Those radicals damage proteins in the parasite. Everybody get that? Okay. So what's the most essential function group responsible for the mechanism of action for this drug? Excellent. The endoperoxide here. Okay? Ring. Questions about that?
Dr. Kashan,
Yes.
you mentioned that this is like a prodrug. Might be a strange question, but it's a prodrug that gets converted to this. But is there a specific enzyme? I know that like there's an enzyme that's responsible. What's that enzyme?
Excellent question. So what's the enzyme that activates this drug? I didn't know the exact enzyme, but I guess if it was something like essential or that influences, the activity, then would be mentioned. Let me see what's happening here. So we have reduction here. So I would assume it's a CYP enzyme because its reduction and oxidation are interchangeable. So it could be one of the CYP enzymes. I'm not sure which enzyme is that, to be honest. Okay. Any other questions on this slide? So far, so good. Okay, to prevent development of resistance, these agents should not be used alone. I mean, we know this already for all the chemotherapeutic agents. For instance, the artemether is co-formulated with lymphantrionine. You might remember this from the 8 substituted quinolones to treat uncomplicated malaria. This one also used in combination with these. Oral rectal intravenous preparations are available but short half-lives to reduce the prophylaxis, use of these agents for prophylaxis. Adverse effects, nausea, vomiting, diarrhea. At higher doses, you may get QT prolongation interval of these agents. Okay, hypersensitivity reactions and rash have occurred. So this is common sense. Of course, you want to combine drugs to increase the activity. And then there is some formulations. Although the IV, these formulations have short half-lives, so they will not be best for prophylaxis. Finally, I guess take home from this slide is the QT prolongation for this drug, just like we've seen with what was it? I forgot already. But you need to know that. Chloroquine. Okay. Sounds good? Okay. Let's see. We have pyrimethamine, which we know its mechanism, and then there is. I'll explain to you. So I think that's the last section, which is pyrimethamine. Now, you guys remember this figure from the antibacterials? Remember when we learned about sulfa drugs? So guys, remember when we learned about the sulfonamides and the trimethoprim? Remember the combination of the sulfamethoxazole, which is a combination? Okay, the same concept apply here, exact same concept. Okay, we have something similar to the trimethoprim, which is called pyrimethamine. And we also have sulfonamides, which is sulfadiazine. Okay, so just to refresh your information, there is something called para-aminobenzoic acid that's converted with the help of these two agents into the dihydropteroic acid, which is converted into the dihydrofolic acid, which is converted into the tetrahydrofolic acid. And this is essential to produce this molecule, which is important for DNA protein and DNA protein synthesis. Okay. Now we could block this enzyme using pyrimethamine, methotrexate, trimethoprim, or we could block this enzyme using sulfonamides. Okay. Of course, we could combine them together. Do we have a special name for combining these two? Remember? Thank you. Sequential blocking. Thank you. So when you have a pathway, you inhibit it in different regions, then we call it sequential blocking. Okay? All right, so pyrimethamine is used in this case. It could also combine with sulfonamide. So that's the mechanism of action for pyrimethamine. Of course, it kills these agents. It could be combined with the sulfadoxazine. Resistance to this combination may develop, and so you would switch to artemisinin. We talked about that. Megaloblastic anemia occurs in the case of pyrimethamine treatment. Okay, now if you have too much of this pyrimethamine and you inhibit the DNA and the RNA synthesis, there's an antidote to help in this case. There's something called leucovorin. Okay, this is an antidote that will be converted into this product here that would help in the synthesis of DNA and protein. So this is in case if you have too much of the pyrimethamine, you would end up having megaloblastic anemia. So you would reverse this effect using an antidote called the leucovorin, also known as folinic acid. Okay, which would allow the synthesis of the nucleic acids without going through, without going through this path. You could just make a shortcut and help this be converted into the nucleic acids, amino acids needed for the protein synthesis. Make sense? So make sure you understand mechanism of action for this, or the sulfadiazine and the pyrimethamine, and the mechanism of this drug here and its importance as an antidote. Eric.
Yeah, like this is specifically for the proteazoa, or is this in our cells?
In our cells. Okay. So now, of course, we have those enzymes as well. I mean, this enzyme we have in our body, but of course, we want to design something that's selective to the protozoa enzyme, but not to ours. Okay. This one here we don't have in our body, so that's nice because you don't have to worry about toxicity. Okay.
Okay. Thank you.
Sure. Any questions? Okay. So this table here is for your own information. Just pay attention that in the case of the pregnancy, you can give chloroquine, mefloquine, but not the other ones, which we talked about already. And then finally, we have these other examples. Now, instead of going through the life cycles of these other classes of protozoals and the drugs, I just want you to know only the example of drugs that act in these cases. So I just want you to know the names that are highlighted in yellow. That's it. So just know that for gardiasis, we use nitazoxanide and we use albendazole. For leishmaniasis, we would use sodium stiboglanate and amphotericin B. Okay, and for toxoplasmosis, we would use sulfadiazine and pyrimethamine and clindamycin. And for trypano, whatever that is, we would use pentamidine, soramine, and all these lists. So don't know their mechanism of actions, just make sure you know for each case what's the list of drugs that acts on them. Make sense? Okay. So start after you finish malaria, we have other examples of protozoal infections. So the only thing I want you to know is just the name of drugs that acts on each case. So gardiasis, I want you to know the name of these two drugs. Leishmaniasis, there are two examples. To the best of my knowledge, it's recorded. Okay, it's showing it's recorded, but just take notes just in case, because sometimes the audio doesn't work or something. The same thing applies to the other cases. Make sense, guys? Everybody get that? Okay, so it's 2:05. Sorry, I think it would be nice to finish all these together. Let's have 10 minutes break, come back and finish the disinfectants and the antiseptics and all that, okay? I'll see you in 10 minutes. Yep, it's still recording.